We are having the same topic that we had discussed on 17th of this month, osteomalacia and osteoporosis. Although from management perspective, we had discussed this, in fact, at a glance, but today we will have detailed management regarding osteoporosis. Osteomalacia we had discussed, but for osteoporosis, we will further discuss in detail. So let me go to the osteoporosis. So this is how we had started. Basically, osteoporosis means the porous bones, which are more fragile and more susceptible to easy fractures, commonly of the spine, hip, and wrist. If you define osteoporosis by DEXA scan or bone densitometry, then we had already discussed all these. We had discussed the process of bone remodeling. There's a periosteoclast. They are converted to active osteoclasts, which lead to bone resorption. And then mononuclear cells are the moderator cells in between these two processes of anabolism and catabolism, where the osteoclast activity that has resorbed the previously formed bones are now taken over by periosteoblasts and then osteoblasts, which lead to the reformation of the bone. And what the process of remodeling and well known. Then osteocytes come into the pili for the mineralization of the bone, and this process goes on. And every 10 years, this process of bone remodeling completes. But with the passage of time, when there is an imbalance between these two processes, osteoclastic activity and osteoblastic activity, if the weight is tilted towards osteoclast, then more resorption than the more bone formation, and the net result will be bone loss, what we call osteoporosis. Clear from up to this? So what this lead to? The strength of the osteoporotic bone is impaired, loss of bone mass, reduction in the bone quality. These are the structural differences between a normal, here you can see normal bony structure, and this is porous bones or osteoporotic bones, more porous, trabeculine pellets and rods, with loss of connectivity. Resorption pits are there, which are called the stress concentrators, and unfavorable geometry overall. So leading to pellet form being set for easy fractures. These are the primary and secondary osteoporosis types. These are the secondary causes. From the primary, we actually mean when there is no underlying cause for the osteoporosis, only age, which leads to the osteoporosis. But if this osteoporosis occurs in a younger age group, then we need to think of some secondary causes of osteoporosis, like hypogonadism, rheumatoid arthritis. As we had said, inflammation leads to the release of cytokines, inflammatory cytokines, which decrease the osteoblastic activity, decrease bone formation, more bone resorption, and the net result will be osteoporosis. These are the secondary causes. The difference is that when you are treating the primary osteoporosis, you have to treat the patient with of course, calcium vitamin D supplements, and plus the anti-resorptive or osteoblastic activity increasing drugs. While in case of secondary osteoporosis, you do give vitamin D and calcium supplements as well, but along with this concomitant treatment of the underlying cause. Say, for example, it was hypogonadism, then you have to replace the hormones, like what you say, if it's in the male, then testosterone need to be replaced, and if it's a female, then the estrogen and progesterone need to be replaced. Rheumatoid arthritis, if it's underlying cause, try to decrease the inflammation to a minimum level, although completely inhibiting rheumatoid inflammation, the rheumatoid arthritis might not be possible, but keep the patient at the lowest level of inflammation so that not that much cytokines are formed which inhibit the osteoblastic activity and increase osteoclastic activity. Then idiopathic hypercalciuria is a condition in which there is increased loss of calcium and phosphorus from the urine for the unknown cause so far. Then tumor-induced osteomalacia also leads to early osteoporosis. But one thing which is notable that in a last lecture we had discussed, when there are secondary causes of the osteoporosis, then the Z-score will also be affected along with the T-score. While if it is idiopathic or primary osteoporosis, then the Z-score is almost always normal, while you have the T-score, which guides you whether the patient is having osteopenia or osteoporosis or severe osteoporosis, depending upon the. Then other secondary cause, we have drugs, glucocorticoids commonly used for asthmatic COPD patient in the inhaled and systemic form. Then steroids are also used for all the inflammatory rheumatological conditions like systemic lupus erythematosus, rheumatoid arthritis, Sjogren's syndrome, polymyositis, dermatomyositis. These all are the conditions which require on and off use of systemic corticosteroids in the form of oral pills or sometimes pulse steroid therapies for severe disease with methylprednisolone. So these all lead to this osteoporosis. Then hyperthyroidism, excessive replacement with the thyroid drugs can lead to osteoporosis. Anticonvulsants are known to cause osteomalacia and early osteoporosis. Lithium, which is used in the bipolar disorder, is also found to be a culprit drug. Then long-term use of heparin or low molecular weight heparin use has also been associated with osteoporosis. Then some drugs which are used in the treatment of prostatic cancer also lead to early osteoporosis. Then aromatase inhibitors, which are used in the breast cancer on a longer term basis, almost 5 years. So these are the cases where you have to address the underlying cause, plus you have to treat these patients as if someone is being started on aromatase inhibitor, we are preempting that this is going to continue for a longer period of time, 5 years, and say patient is osteopenic, then even you have to treat the osteopenia at this stage. So that patient might not develop full-fledged osteoporosis and fractures can be prevented. Methotrexate, cyclosporin A, some sedatives, although not directly involved in the osteoporotic one, but they lead to the more sedation and risk of fall is increased and leading to increased fractures. Total parental nutritions, although now they are very much fortified with the bone-friendly contents, but yet is known to be a cause of osteoporosis. This we have already discussed, that increased resorption and normal decreased resorption that occurs. Here is the bone densitometry determinants according to T-score. See if your T-score is in pillars, that's say for example from 0 to 1 or even up to H minus, there is very minimal risk of developing fractures. But as your bone mass decreases, say from the low bone mass, this is osteopenic stage. When you are reaching here, the curve is now rising. And when you actually reach -2 or less than -3, -4, or -5, this is going to peak, and the risk of the fractures increases many folds. So there is linear relationship between the bone mineral density and the risk of fractures. It's directly proportional. These are all the factors leading to the fractures. You have to try to avoid and minimize these. Clinical features we had discussed already, but just for the purpose of revision, It's a silent disease, silent killer sometimes cause, because there are no symptoms of osteoporosis until unless there is a fracture, which leads to the pain in the involved site. Lower backache with uh, dorsal kyphosis and loss of height are the features which alert someone to the development of osteoporosis. Fracture most commonly occurs at the sites of hip and vertebral areas. This loss of vertebral height and compression of this vertebrae leads to the kyphosis, as well as loss of the height, and patient bows down with the passage of time. This is how normal vertebrae are looking like. This is normal, and then biconcavia or codfish deformity earlier, then the wedge fracture, and this is complete collapse fracture of the vertebra. This is how it looks like. This is the compressed vertebra, totally compressed vertebra. You see the difference between the heights of this vertebra, the vertebra below this and the involved. This one is very much compressed and total loss of height. Here is also at the earlier stage, there is concavity that has developed, there is wedging, and if not addressed at this stage can lead to this. And here you actually cannot reverse the things. So try to preempt, be proactive as far as your bone density is concerned. Need to take good calcium and vitamin D supplements, and get your risk of osteoporosis assessed by a rheumatologist if you are having any risk factor regarding osteoporosis. This is Cooley's distal fracture of the radius of the easy or low impact trauma or injury. Here, the DEXA scan is the diagnostic gold standard for bone mineral density. And this is how we classify this. This is the normal -1 or greater, that is up to 0, then 1, +1, up to -1 is normal. Then between -1 to -2.5, this is osteopenia. And if it's less than -2.5, 2.5 or less than -2.5, this is osteoporosis. And if along with this bone mineral density or even lower, you have any history of fragility fracture or low impact trauma fracture, then this is by definition is severe osteoporosis. So severe osteoporosis is not related directly with the score. You may have bone mineral density score, T score of -3.5, -4 even, but if there is no fracture, you still call this as osteoporosis, not severe osteoporosis. The severe osteoporosis is when there is fragility fracture. I hope this point is also cleared. If someone asked you the definition of severe osteoporosis or difference between osteoporosis and severe osteoporosis, so it's not the densitometry only, but for severity being called as severe osteoporosis, you need to have a fragility or low impact trauma fractures. And this is how we have already discussed, we calculate. Now the question arises, when and whom should be tested for bone mineral density. The definition, by definition, if the woman is of 65 years of age or older, and male at the age of 70 years or older, need to have a bone mineral density done, or DEXA scan need to be done to see the risk of osteoporosis. In postmenopausal women and men above the age of 50 and 69 based on a risk factor profile. Say, for example, what does this actually mean? If someone is not matching the criteria of age, say, for example, at 50 years or 55 years, usually this is not the age for getting a bone mineral density or DEXA scan. But if someone is having an additional risk factor, say for example, patient is asthmatic with chronic use of corticosteroids, inhaled or oral or injectable, or someone's having an inflammatory condition like rheumatoid arthritis, then this age criteria might not be the only factor. You get bone mineral density or DEXA scanning done even at the age of 50 or 55 years. So if there is an additional risk factor present for development of osteoporosis, you get a DEXA scan even at the earlier stage. In postmenopausal, a female and male age of 50 or and older who had an adult fracture to diagnose and determine the degree of osteoporosis. If there is any fracture of low impact trauma or injury, then one need to be alert that why this fracture has occurred. Then at that stage, you might also be testing bone mineral density by DEXA scan. Which women men with osteopenia should be treated? Those who have risk factor for fractures or an additional condition along with this T score. Say, for example, T score of -2 without risk of risk factor for fracture, or T score of less than -1.5 with risk factor for fractures. This is actually bone mineral density form. These both are at the stage of osteopenia, not the osteoporosis. But if you have this result of T score at DEXA scan or bone mineral density testing, and you have an additional risk factor that we had already mentioned, then these are the patients that still need treatment if although they are not meeting the criteria of osteoporosis. But this was the somewhat older thought process, but newer one is now going for FRAX scoring system, which actually calculates the risk of osteoporosis in the next 10 years. There are some parameters which need to be filled. This is FRAX. WHO FRAX risk calculator estimates 10-year patient-specific absolute fracture risk at hip and major osteoporotic fractures with spine, forearm, hip, and shoulders. Evaluates the fracture risk from epidemiological data, the countries which are mentioned. Integrates clinical risk factors as well as BMD, femoral neck. Here in the previous National Osteoporosis Foundation recommendation, NOF Foundation recommendations, it was totally based on the T score. But here they are also incorporating into it the clinical risk factors as well, apart from the absolute T score values. This is how you find the on internet FRAX scoring system. These are its pre-requirements, which are filled with age, DEXA scan, T score, and then you have these parameters: weight, height, previous fractures, history of fracture in the parents, current smoking status, glucocorticoids, and rheumatoid arthritis. These are all the factors for secondary osteoporosis. So that's why these are incorporated, and then total scoring is calculated, and this gives you the net result. If the 10-year scoring risk of fracture is more than 2 to 3%, then these are the patients that need treatment. Otherwise, it's only the observation. Now coming to the previously we had non-pharmacological. This is good diet containing healthy wet calcium, vitamin D supplements. Exercise, daily exercise, and weight bearing. These are all the non-pharmacological modalities that are incorporated in the treatment of osteoporosis. Even with this, you can prevent the osteoporosis for a certain period of time. Now we are coming to the pharmacological or drug treatment of osteoporosis. These are the non-pharmacologic: calcium, balance exercise, vitamin D, decrease alcohol, stop smoking. If there are any causative agents leading to osteoporosis, try to eliminate that. These are very important steps that need to be foolproof system at the home. No slippery tiles at the washrooms, and then non-slippery footwears need to be used. Hip protectors are used in order to avoid the if in case God forbid there is any fall that can lead to fractures. So using hip protectors, that can be avoided. Then we have these medications, major groups. Anti-resorptive treatments are bisphosphonates, and then selective estrogen receptor modulators, then calcitonin, estrogen, and rank antibodies. That's denosumab. We will discuss later on. These are anabolic drugs which lead to increased osteoblastic activity, teriparatide and ostrontium ranelate. We had already discussed this non-pharmacological, then pharmacological. These are the drugs where these drugs say anti-resorptive work over here, inhibit your active osteoclast and decrease bone resorption. This leads to increased bone formation. Osteoclastic activity is inhibited, and osteoblastic activity increased. The net result is bone formation or avoiding the osteoporosis. Now, what we have available are in Pakistan over here. We have different type of bisphosphonates which are available. Some are oral, some are injectables. Their benefits and will be discussed over here. Zoledronic acid is the reclast is out of Pakistan. In Pakistan, it's with the name of Aclasta. 5 milligram once yearly is 100 ml infusion given once yearly. This is the long-acting bisphosphonate that we are having over here. Alendronate or Fosamax. If you are using this for prevention of the osteoporosis, say for example, if someone is having osteopenia and risk factor for osteoporosis like use of corticosteroids or rheumatoid arthritis, 35 milligram per week, once weekly, oral tablet is given. While if you are having osteoporosis, so this would be the treatment, not the prevention, then 70 milligram per week per orally is given. There are some precautions and suggestion for the patients. If they are taking oral bisphosphonates, it should be taken at the empty stomach early in the morning with 1 glass of water, and patient should not lie down or bow down for up to 30 minutes as this leads to the reflux of the contents of the drugs, and this leads to severe esophagitis. So always inform your patient that need to be taken empty stomach with 1 glass of water, and for 30 minutes you have to either sit upright or walk around within the home for 30 minutes, and then you may have your routine breakfast and can take other medications. There is also, it comes with the name in Pakistan, DRATE, D-R-A-T-E, DRATE. And then if it's in combination with vitamin D, DRATE D is also available along with additional vitamin D. 2000 inter units, units are 5600 internet units depending upon the vitamin D needs. Then we have risdronate, which is also bisphosphonate. This is also weekly. 35 milligram per week or 150 milligram once monthly. Both regimes are available. The recommendations for taking oral are same as I already mentioned. First thing in the morning with 1 glass of water, and not to sit or lie down for 30 minutes. Then we have abendronate with the name of Bone Viva over here. It's also both injectable and oral form is available. Oral form 150 milligram once monthly per orally to be taken as already mentioned, or 3 milligram IV pulse every 3 months. But among the bisphosphonates, abendronate is the weakest of bisphosphonate, and studies regarding hip fracture prevention are very much limited. So I personally do not prefer this drug to be taken if the patient is having osteoporosis, although it prevents the vertebral fractures, but not the hip fractures. So not a good choice. What are the side effects of these bisphosphonates? Hypocalcemia, which sometimes may lead to tetany. So always inform your patient that if you are taking bisphosphonates, adequate supplements of calcium and vitamin D need to be taken. 1200 milligram of calcium per day, along with vitamin D 800 milligram. If you are not giving, because this actually deposits the calcium within the bones. So as a result, serum levels of the calcium are decreased, which lead to tetany, spasm, and even sometimes fits. I have seen one patient during my residency of second FCPS rheumatology. One patient was given zoledronic acid, and after 2 weeks, patient came with a tetany, with spasm of the hands. So this also need to be taken into account whenever you are prescribing bisphosphonates. Always ask your patient that this is the calcium supplement that need to be taken on regular basis. Then the osteonecrosis of jaw was a concern, but data regarding this is more in the patients who are treated for hypercalcemia of malignancy, because bisphosphonates are also used in the hypercalcemia of the malignancy apart from osteoporosis. So the majority of the cases that are reported are actually those who are treated for malignancy. But still, if your patient is having any problem with the dental problem, that need to be taken into account, and no dental procedure should be undertaken for next 3 months after the use of bisphosphonates. Common infusion reactions are flu-like symptoms, low-grade fever. These are commonly seen, last for 2 to 3 days, treated with symptomatically with acetaminophen. Then we have teriparatide with the name of Forteo. Appears to create new trabeculae, increases osteoblastic activity, as we here see. What previous drugs were doing, these were inhibiting the osteoclastic activity. Actually, this is here. Your anti-resorptive or bisphosphonates work, inhibit resorption, while these are the anabolic drugs. They actually increase the belastic activity. So anabolic effect leading to bone formation. This is given subcutaneous daily pulse doses. This is the only drawback that we have. Adverse effects are not commonly reported. Avoid in patients with hyperparathyroidism. So before starting, because it's a synthetic product analog of your parathyroid hormone. So before starting this, always check serum PTH levels and calcium. If the patient is having hypercalcemia or very high PTH levels, then this is not the good choice. This rather need to be avoided. There is also a risk of osteosarcoma. If someone is having any bony soft tissue malignancy, this agent need to be avoided in those patients. Then we have denosumab monoclonal antibody. It is a fully human monoclonal antibody, binds the rank ligand, which is receptor activator of nuclear kappa. prevents rank ligand from activating the rank. It's on its receptors on osteoclast surface. So as a result, what happens if rank is not binding with the rank its ligand, the osteoclastic activity is inhibited. So as a result, no bone resorption occurs and belastic activity continues, leading to net bone formation rather than bone loss. With reduced rank ligand osteoclastic formation, function and survival are inhibited. As a result, bone resorption is decreased and formation increases, that I already mentioned. There is ease of use. Subcutaneous injection, you just give like insulin, 60 milligram subcutaneous every 6 months. Side effects are dry, itchy skin, crusting, sometimes blisters may form, back pain, muscular aches and pains and joints pains may also occur, but for a temporary period of time, it can be treated symptomatically. If already there are any fractures due to osteoporosis, orthopedics need to be taken on board, and fractures need to be treated surgically. One thing which I forgot to mention over here, for how long? So if the patient is having osteoporosis, there was previously that you use for bisphosphonates for 5 years, then drug-free interval of 2 to 3 years be given, and then restarted. But now we have data of up to 10 years regular continuous use of bisphosphonates, so with no active issues. The other thing which comes when to switch one product, one treatment model to another, is if you are having osteoporosis, you treat the patient for 2 consecutive years and then repeat the DEXA scan. This is the recommendation for repeating DEXA scan, not before 2 years. After 2 years, you see if the T score is either improving or it's at least static, it's not worsening, then you may continue with that drug. But if the T score is worsening and going into more minuses, then you have to switch from one drug to another. Now combination therapies of bisphosphonates along with the teriparatide have also been used with some good results. So what are the clinical challenges that we are having in treating the osteoporosis? It's delayed diagnosed because of there's no awareness among the general public. Number 2, it's asymptomatic usually until a fracture occurs. By that time, you are already late. It means the your bone mass has already lost. Even after some fractures, 2/3 of the vertebral fractures are asymptomatic. So the challenge to the clinician: identify the patient who are at high risk for fractures, prevent first fracture. The most serious health consequence of osteoporosis is a fracture. Spine and hip fractures especially may lead to chronic pain, long-term disability, and even death. The main goal of treating osteoporosis is to prevent fracture. This should be the target. So if you have osteoporosis, it's important to help not just further bone loss, but also a fracture that need to be prevented at every cost. Here are some ways to decrease your chance of fall. Use walking aids if you are unsteady, using cane or walker. Remove hazards in the home. Remove through rugs. Also remove or secure loose wires. Cables that might trip add night lights in the hallways leading to the bathrooms. Install grip bars in the bathrooms, non-skid mats near sinks and the tub, so that the slipping of the patient be avoided and fractures can be prevented. Get help carrying or lifting heavy items. If you are not careful, you could fall or even suffer a spine fracture without falling. Wear sturdy shoes. This is above all true in winter or when it rains. So the points to remember: make sure that there's enough calcium and vitamin D in your diet. Be physically active. Do weight-bearing exercise wherever possible, like walking most days each week. Change lifestyle choices that raise your risk of osteoporosis. Implement strategies to help decrease your risk of falling. So, eat high calcium food, exercise regularly, do not smoke at younger age to prevent osteoporosis and fractures. So, don't let your bones age faster than you. Thank you very much. So, if there are any questions or सारे क्वेश्चन के लिए कुछ आ जाएंगे खुद ब खुद? How one question have come: how costly is DEXA scan? DEXA scan costs vary at different centers, but from 4 to 6,000, it's usually done. So we have another question, that Z score. So that last time this question also was asked by some of our students. Z score actually is the tells you about the quality of the bone, and usually it signifies any secondary cause leading to osteoporosis, any metabolic bone disease. So if there is only problem with your T score and Z score seems okay, then it means it's the bone that has aged with the passage of time and now leading to the osteoporosis. But along with T score, if Z score is also bad, then you may have actually underlying metabolic bone disease like osteomalacia, decreased vitamin D, calcium levels, Paget's disease. These are all the causes that lead to deterioration in the Z score. So if someone is having, say for example, T score in the osteoporotic range from minus 2.5 and less, and along with Z scores also in the minus 2.5 or 3, then you don't have only to treat as osteoporosis, but you have to treat that patient might be in severe deficiency of vitamin D. So mega doses of, and for those cases, you won't give daily requirements which are needed for osteoporotic patient, like 800 milligram of calcium, 8 to 1200 milligram of calcium, and 6 to 800 milligram of vitamin D. But rather you need mega doses of vitamin D, which of course need to be checked first, and 2 lakh international units every 15 days for 6-7 doses, depending upon how much deficient is the patient. So this Z score alerts you about the quality of the bone that has led to the osteoporosis. The bad quality of bone because of some other content deficiencies is signified by Z score. Any other question? I think don't we have.